Real-world data is a term that many people debate its meaning, but largely it's meant to mean the experience of CLL patients treated with chemotherapy or novel therapeutics outside of the context of clinical trials. Very important area of study because most patients with CLL are treated outside of the context of clinical research, and there are some differences between patients treated in clinical practice and patients who are treated on clinical trials. Trial patients tend to be younger, they're more fit, they have more resources, they're able to travel to large tertiary care centers to participate, they have less comorbidity, they have better organ function, and so trying to understand whether or not drugs perform in real world or in clinical practice the way that they performed in the context of a highly specialized clinical trial is an important area. I think it really speaks to the process of informed consent. When we sit down with a patient, we want to really be able to tell them what does the toxicity profile look like in someone specifically like them. How will the drug perform in terms of progression-free, overall survival, response rates? Are there differences that we've observed between our practices and what we observed in the context of clinical research? This is where this area of research is coming from. I think probably another very important area is the fact that as novel agents are being developed and approved, they're often compared to controls that are standards of care, but not necessarily relevant standards of care in most countries. Chlorambucil would be a good example. Anti-CD20 monoclonal antibodies as monotherapies would be another example. Very few head-to-head comparisons between novel agents have been performed or reported, and so we're left with a situation where we have a wealth of riches, 3, 4, 5, 6 drugs approved in a space and no comparison of any of them and no data on how to sequence when one fails, which is where these studies, which are imperfect and have limitations and potential biases and different quality data, are really important because there are very often no planned prospective studies to answer these questions. And so we're left with these data gaps, and this is where this type of evidence can come in handy. If not to affect current practice, but also maybe to inspire what are appropriate decisions for future clinical trial design. Specific examples are we go where the practices go. And so initially the studies that we performed looked at ibrutinib and idelalisib. We tried to understand reasons for discontinuation. There we found AEs or toxicities were the most common reasons for discontinuation. We also looked at outcomes and tried to decide whether or not there are patient populations who have different outcomes either because of an inherent molecular or genetic defect or because of the fact that they are underdosed, for example. Some of the areas that we've looked at are switching between kinase inhibitors in the setting of progression. Again, reasons for discontinuation, outcomes for patients treated with lower than FDA-approved doses of these drugs is just one example for kinase inhibitors. In venetoclax, we're asking sequencing questions about what happens after venetoclax is stopped, whether or not you do need a combination with an anti-CD20 antibody, what happens in our practices in terms of tumor lysis syndrome risk. Is it higher? Are there other predictors besides traditional risk stratification? Are some of the areas that we're focusing on. As new drugs become approved, like acalabrutinib, if it becomes approved, or duvelisib, which has had a recent approval, or other drugs, then the direction will shift in terms of what's being used and how are those drugs being tolerated. So it's not like there's a specific target or a specific comparison. We observe what happens and then report it and try to ask questions based on those patient populations.